Welcome back to the deep dive. You hand us the dense, complex academic material, in this case, an entire textbook chapter on specialized connective tissue, and we take on the mission of extracting the essential knowledge,
Our goal is to give you a clear, structured guide to mastery.
a true shortcut to being well-informed.
And today, we are undertaking a comprehensive deep dive into the histology of cartilage. This is all from Chapter 7.
And cartilage, it might seem sort of inert, but it's one of the most mechanically sophisticated tissues in the body.
Oh, absolutely. It's incredibly dynamic, it's essential, and it dictates everything from the foundation of the fetal skeleton to, the cushioning that keeps your joints moving smoothly for decades.
So we're going to step through this chapter structure by structure, starting with the big picture and then really drilling down to the specific molecular architecture.
And a crucial part of this is making sure you can actually visualize the tissue, even without the textbook open in front of you.
Exactly. So we'll be verbally describing all the key structural relationships, the cell organization, and of course the clinical correlations to really build that visual roadmap in your mind.
And the central theme, really, that organizes everything we're going to discuss today is the unique nature of this tissue. It's almost entirely defined by two fundamental properties.
Okay, what are they?
First, it's overwhelmingly composed of its matrix. We're talking upwards of 95% of its total volume.
95%.
And second, it is avascular. Completely.
Yeah.
No blood vessels penetrate this tissue.
And that lack of a direct blood supply, that's
Yeah.
the key limitation, right?
It's the functional trade-off. It dictates everything we're about to cover, especially its profound inability to repair itself.
Okay, so let's start at the beginning, the overview.
Let's do it.
When you look at the fundamental definition, cartilage is a specialized form of connective tissue.
Right.
And it's composed of two primary elements. The cells, which are called chondrocytes, and this complex, specialized extracellular matrix, or ECM, which they produce and maintain.
And that ECM, as I mentioned, is the absolute functional element. If you were looking at a typical micrograph of cartilage, the sheer vastness of the matrix compared to the sparse cells would be startling.
So the cells are almost just there.
They're almost incidental in terms of volume. They make up only about 3 to 5% of the mass. But they are vital, of course. The matrix is the machinery.
And this matrix isn't just random filler.
Not at all. It's solid and firm, but at the same time, it remains pliable.
And that combination gives cartilage its defining property, resilience.
Exactly. Resilience. That allows it to bear weight, to absorb shock, and provide those low-friction surfaces, particularly at synovial joints.
And it also serves as that crucial template for most of the bones that develop in the fetus.
Now, let's circle back to the vascularity for a second.
Okay.
If there are no blood vessels, how do the chondrocytes, which are scattered far and wide in this matrix, how do they survive?
They have to rely entirely on diffusion.
Purely on diffusion. The matrix composition is engineered to facilitate this. Well, the high concentration of these highly charged molecules, the glycosaminoglycans, or GAGs, combined with the type 2 collagen fibers, creates a structure that allows nutrients and waste products to diffuse effectively.
Oh, where?
From the blood vessels that sit in the surrounding connective tissue, all the way to those distant chondrocytes.
So you can think of the matrix as this highly organized, dual-component system.
Yes, perfectly put. It's designed for compression resistance. You have the collagen fibril meshwork, which provides tremendous tensile strength.
Kind of like rebar in concrete.
Exactly like rebar. It resists tension and that internal swelling pressure. And then you have the second part, the heavily hydrated proteoglycan aggregates.
And these are weak and sheer, but they function like a dense, water-filled sponge held within that collagen net.
Precisely. So when you compress the cartilage, you squeeze some of that water out, but the resilient proteoglycans immediately pull that water right back in.
Which allows the tissue to bear weight while still remaining pliable.
That's the mechanism.
Okay, that's the general blueprint. Now, this is where it gets really interesting. We distinguish the three specific types of cartilage based purely on how they tweak the ingredients of that matrix.
Yes, and that fundamentally alters their mechanical role in the body. We categorize them based on the dominant fiber types they contain and, critically, their reaction to aging and development.
So let's start with number 1, hyaline cartilage. This is the most common one, right? The foundational blueprint we've just been discussing.
It is. Its matrix features are that standard set. Type 2 collagen, the GAGs, proteoglycans, and a few multi-adhesive glycoproteins.
And functionally, it resists compression, provides that incredibly smooth, low-friction surface at joints.
And offers structural support, especially in the respiratory system.
So you find it in places where you need that rigidity and smoothness. The fetal skeleton.
The growth plates, or epiphyseal plates.
Articulating surfaces of movable joints. The costal cartilages.
And the structural components of the nasal cavity and the larynx, specifically the thyroid, cricoid, and arytenoid cartilages, and, of course, the rings of the trachea.
Now, a key structural distinction for hyaline cartilage is that it's typically surrounded by a perichondrium.
Right, that dense connective tissue layer. But there are exceptions.
It's not on the free surfaces of articular cartilage.
Or at the epiphyseal plates. And functionally, and this is important, hyaline cartilage does calcify.
Both during normal growth, like an endochondral bone formation?
And just inevitably as part of the aging process.
Okay, so moving on to the second type, elastic cartilage. You can think of this as sort of hyaline plus.
That's a great way to put it. It contains all the standard hyaline components, but its matrix is laced with a dense network of elastic fibers and these elastic lamellae.
And that addition fundamentally changes the tissue's role. It's not just about compressive resistance anymore.
It's about elastic recoil and flexibility. Location-wise, it's everywhere you need structure that can bend and snap back.
Like the external ear, the pinna.
The walls of the external acoustic meatus, the auditory tube, the epiglottis.
Critically, elastic cartilage always has a perichondrium surrounding it.
Always. And, unlike its hyaline sibling, it does not calcify with age.
So it retains its elastic properties throughout life.
That's right.
Okay, finally, fibrocartilage. This is the definitive hybrid, the heavy-duty option.
It's where dense, regular connective tissue meets hyaline cartilage.
And the big distinguishing feature of its matrix is the presence of abundant type I collagen fibers.
Yes, that's the strong, thick, tensile collagen you see in tendons and ligaments. It has that in addition to the type 2 collagen from the hyaline matrix.
Which means it can resist two very specific, demanding mechanical forces.
Exactly. That combination of fibers makes it the ultimate shock absorber. It can resist both compression and immense shearing forces.
So you'd find it in the intervertebral discs.
The pubic symphysis and the menisci of the knee joint. And structurally, like articular cartilage, fibrocartilage does not have a perichondrium.
That gives us a great foundation. Let's really focus now on the most common type and the main subject of the chapter, hyaline cartilage. Let's dive into its exquisite molecular detail.
Sounds good.
So, hyaline cartilage, the name literally means glassy, and that homogeneous, amorphous, glassy look is a direct result of its matrix composition.
Its role is simple: low friction, dry lubrication, and efficient distribution of applied forces.
And we really have to internalize the structure of this matrix because it explains everything.
It does. As we said, 60 to 80% of the net weight of cartilage is just water.
And that water is tightly bound by the proteoglycan aggregates.
Right. Collagen is about 15% of the dry weight, and the sparse chondrocytes are the rest.
So let's break down the three major molecular classes that make up the solid part of this matrix.
Okay, first up, collagen molecules. Type 2 collagen forms the bulk of the thin, short fibrils that create that resilient 3D meshwork.
But it's not the only one.
Not at all. To function correctly, this network requires these auxiliary collagens that act as organizational anchors and regulators.
And we need to know 4 other cartilage-specific collagens, and this is where the nuance is critical.
It is. So you have type IX, which links the fibrils to the proteoglycans.
Okay.
Then type X is the size regulator for the fibrils.
Right.
But if you had to pick 2 collagens beyond type 2 that really dictate function, it would be type X and type 6.
And why them specifically?
Well, type X collagen is absolutely essential because it organizes the fibrils into a specific 3-dimensional hexagonal lattice. That lattice is the mechanical basis for the whole tissue's function.
And type 6.
Type 6 collagen is the anchor. It's found right at the cell surface, ensuring the chondrocyte is securely attached to the surrounding matrix structure via integrin receptors.
Okay, so that's the collagen. The second class is the proteoglycans.
The ground substance here contains 3 critical GAGs:
The hyaluronan.
chondroitin sulfate and keratin sulfate.
And the MVP of this whole system is what?
Aggrecan. Without a doubt. Aggrecan is the primary proteoglycan monomer, and it's massive. It's encoded by the aggrecan gene.
And each monomer carries about 100 chondroitin sulfate chains and up to 60 keratin sulfate chains.
All of which impart an enormous negative charge.
So you can think of aggrecan as this giant bottle brush, right? Stiff and bristly, covered in negative charges.
Yes, and these negative charges repel each other intensely, forcing the molecule to expand and giving it an extremely high affinity for water.
Making it the primary mechanism of resilience.
Exactly. And this is where the true scale comes into play. These aggrecan monomers don't work alone. They bind to a single, long, linear hyaluronan molecule.
How many?
Over 300 aggrecan monomers will attach, stabilized by link proteins, forming a gigantic complex proteoglycan aggregate.
So you have to visualize this. You have this massive, highly charged, water-sucking aggregate, and it's physically trapped within that stiff, non-extensible net of type 2 collagen fibrils. The water generates a high osmotic swelling pressure, and the collagen network resists that pressure. And that dynamic tension is the definition of cartilage's mechanical property.
It is, and the loosely bound water is also key, acting as the transport mechanism for diffusion. We also have other stabilizing proteoglycans like dicorin and biglycan, which fine-tune the structure, but they don't form those large aggregates themselves.
And finally, the third class, multi-adhesive glycoproteins.
These are non-collagenous proteins that mediate cell matrix interactions. Key examples are ankyrin CII, which is the collagen receptor that type 6 collagen hooks onto tenacin, and fibronectin.
And beyond their structural role, these are useful because they serve as essential biochemical markers.
Right, for observing cartilage turnover and degeneration.
And it's crucial to remember that this is a living system.
Constantly remodeling. Chondrocytes detect changes in matrix load and structure, and they respond by synthesizing new molecules. Pressure loads, especially in synovial joints, generate mechanical, electrical, and chemical signals that literally tell the chondrocyte what to do.
But the problem is that with age, the chondrocyte's ability to correctly perceive and respond to these signals, it diminishes significantly.
It does, and that leads us right into the first clinical correlation.
So now that we understand this intricate, nearly perfect balance of the hyaline matrix, the most common joint disease, osteoarthritis, or OA, reveals what happens when that balance breaks.
OA is widespread. It's tied to aging and injury, affecting the majority of people over 65, particularly in weight-bearing joints like the hips, knees, lumbar spine.
Hands and feet as well.
Yes. And the core histological pathogenesis is simple but devastating. There is a marked decrease in the overall proteoglycan content, specifically aggrecan,
So if you lose the charged sponges, you lose the ability to bind water.
which results in a severe reduction in intracellular water content. The tissue just loses its resilience.
And the cells, the chondrocytes, they actually turn against the matrix.
They do. Pro-inflammatory cytokines, especially interleukin-1 and TNF-alpha, effectively tune the chondrocytes into demolition workers. They stimulate the release of metalloproteinases, the MMPs, and at the same time, they inhibit the synthesis of new type 2 collagen and proteoglycans.
So let's pause on those MMPs. They are never really defined clearly in the text, but they're critical.
Right. Metalloproteinases are a family of enzymes that contain zinc, and their job is to degrade various components of the extracellular matrix.
So in normal remodeling, they're the necessary cleanup crew.
But in OA, they become the uncontrolled demolition team. They just chew away at the type 2 collagen net and the protein cores, leading to total structural failure.
And the physical result is joint destruction.
The superficial layer gets disrupted, cracks form, and eventually the destruction extends through the cartilage layer entirely. The body tries to compensate, but the exposed subchondral bone becomes the new, rough, abrasive articular surface.
Which leads to chronic pain, reduced mobility, and eventual disability.
And unfortunately, since there's no cure, treatment remains focused entirely on pain management and maintaining mobility. You're addressing the symptoms, not the root histological failure.
So let's return to the cells and how they organize the matrix they create. Chondrocytes aren't just randomly scattered.
No, they exist either singularly or in these dynamic clusters called isogenous groups.
And these groups are formed when a chondrocyte undergoes mitotic division.
So these are cells that have recently reproduced. And if you look closely at active chondrocytes, you can see their metabolic status reflected in their cytoplasm.
They exhibit cytoplasmic basophilia.
Meaning they're actively synthesizing proteins, they're just packed with rough ER. You also see these clear areas, which represent a large Golgi apparatus dedicated to packaging and exporting those vast matrix components.
And to allow these isogenous groups to expand, the cells have to locally dissolve the matrix around them.
Which is why they secrete those same MMPs we just discussed. They're essential for internal expansion.
Now, crucially, the matrix composition isn't uniform. It's geographically organized.
Into three distinct regions defined by staining differences which reflect functional specialization. You can imagine the chondrocyte or the isogenous group as a small island.
Okay, so right around that island is the capsular or pericellular matrix, the dense immediate shoreline.
And it's the most intensely staining ring because it has the highest concentration of those highly charged sulfated proteoglycans, hyaluronan, and big glycans.
So functionally, this is the cell's anchor zone.
It is. It contains almost exclusively type 6 collagen, tightly connecting the cell to the overall structure via integrin receptors.
Moving outward from that, we find the territorial matrix.
This is the immediate coastal shelf surrounding the entire isogenous group. It stains less intensely than the capsular matrix because it has a lower concentration of sulfated proteoglycans. It's composed of a more random network of type 2 and type IX collagen fibrils.
Okay, and finally, we reach the interterritorial matrix.
This is the bulk of the open ocean, the largest volume, occupying the space between the distinct groups of chondrocytes. And understanding these regions is important because mechanical forces and nutrient diffusion gradients differ substantially between the immediate cell periphery and the bulk matrix.
That makes sense. Let's move on to cartilage development.
The foundational role of hyaline cartilage is its involvement in forming the skeletal system. In the fetus, hyaline cartilage forms the precursor models of most bones that develop through a process known as endochondral ossification.
So these initial cartilage models, they mirror the ultimate shape of the long bones.
They do. And as the fetus and child grow, the vast majority of this cartilage is systematically removed and replaced by bone tissue.
But some residual cartilage remains at critical growth sites.
The most famous examples being the epiphyseal growth plates or epiphyseal discs, which separate the epiphysis from the diaphysis at the ends of growing bones.
And these function as the engine of lengthwise bone growth until skeletal maturity.
Right. And in the adult, the remnants that endure are the articular cartilage covering synovial joints, the costal cartilages connecting ribs to the sternum, and the cartilages providing rigid structure to the respiratory system.
Now, most of these cartilage structures are encapsulated by the perichondrium,
a layer of dense, irregular connective tissue that firmly attaches to the cartilage surface. It acts essentially as a reservoir and a source of new cells.
And when the cartilage is actively growing, this capsule divides into two functionally distinct layers.
You have the outer fibrous layer with flattened fibroblasts and type I collagen fibers, and then you have the intercellular layer.
And this is the layer that generates new cartilage cells.
Exactly. Its cells are chondroprogenitor cells, just waiting for the signal to differentiate into chondroblasts and begin secreting matrix.
But we have to stress the exception again, where the cartilage serves as a bearing surface.
At the articulating joint surface and at the epiphyseal plates.
The perichondrium is absent.
And that structural reality is the primary contributor to the repair limitations we'll discuss later.
Which brings us to articular cartilage zones. This is the specialized hyaline cartilage covering movable joint surfaces.
It's tough, typically 2 to 5 millimeters thick, and precisely organized to handle massive loads without the aid of a perichondrium on its free surface.
And because it has to withstand forces coming from every direction, its structure is organized into 4 distinct zones, arranged from the joint surface down to the bone,
with cells and fibers precisely aligned to resist load. Let's walk through the architecture layer by layer.
Okay, starting at the very top, closest to the joint fluid.
That's the superficial or tangential zone. The SC, this is the thin, pressure-resistant layer. The chondrocytes here are elongated and flattened, lying parallel to the surface.
And functionally, the type 2 collagen fibrils are also arranged in dense fascicles that run parallel to the surface.
Right, to resist friction and shearing forces.
Okay, beneath that is the intermediate or transitional zone, the IZ.
And as the name suggests, this is the changeover region. The chondrocytes become rounded, they lose that flattened appearance, and they're distributed randomly.
And the collagen fibrils?
They start to transition, becoming less organized, often oriented obliquely. This zone is visible in staining as intensely red due to the high concentration of sulfated proteoglycans.
Next is the deep or radial zone, the TZ.
And here, the organization is dramatic. The small, round chondrocytes are arranged in short, distinct columns running perpendicular to the joint surface.
So the collagen fibrils are positioned between these columns, also parallel to the long axis of the bone.
Exactly. This arrangement is optimized to resist large compressive forces pushing down on the joint.
And finally, at the very bottom is the calcified zone, the CZ.
This zone is adjacent to the bone, where the matrix has mineralized with calcium phosphate crystals.
And this interface is structurally critical. We find two key lines here.
We do. The tidemark is the smooth, heavily calcified line separating the deep zone from the calcified zone.
And chondrocyte proliferation for interstitial growth, if it happens above this line.
Right. And the cement line located below that defines the actual junction between the calcified zone and the underlying subchondral bone.
So it's necessary to emphasize again that renewal in mature articular cartilage is almost non-existent.
The stability of the type 2 collagen, the long life of the proteoglycans, and the naturally low MMP activity mean that once damage occurs in this architecture, it is exceedingly difficult for the tissue to renew itself.
Okay, let's switch gears to the other two major types, starting with elastic cartilage.
Right. As we noted, structurally, it's hyaline cartilage with a specialized addition, the presence of elastin.
And functionally, that addition is everything.
It is. Elastin forms this dense, complex network of highly branching and intercommunicating elastic fibers and sheets woven throughout the type 2 collagen matrix.
And if you were looking at this histologically, you wouldn't see these elastic fibers with routine H&E staining.
No, you need specialized elastic stains like resorcin fusin or orchisin, which highlight the fibers in brown or purple. That visual confirmation is essential to distinguish it from hyaline cartilage.
And this elastin network gives the tissue its elastic properties, the ability to be deformed and snap back to its original shape,
while still retaining the underlying resilience and pliability derived from the hyaline components. It's the perfect combination for structures that must move constantly, like the pinna of the ear or the epiglottis.
And its great survival feature is that its matrix does not calcify with age.
Unlike hyaline cartilage, this means the tissue retains its elasticity and function throughout the lifespan. And it's always surrounded by a perichondrium, which gives it a slightly better chance at superficial repair.
Okay, and on to fibrocartilage, the hybrid tissue.
Its definition under the microscope is that it's a combination of dense, regular connective tissue, like a ligament, and hyaline cartilage. And like articular cartilage, it stands alone. It lacks a perichondrium.
Visually, it looks fibrous. The chondrocytes are dispersed among these thick, parallel bundles of collagen fibers.
They might be in rows or isogenous groups, but they're clearly separated by massive amounts of fibrous material. And you can differentiate the cells because the chondrocyte nuclei are rounded, with a small halo of matrix.
Whereas the fibroblast nuclei embedded within the massive collagen bundles are typically flattened and elongated.
Right. Functionally, it is found where the body needs a massive buffer. It must resist both powerful compression, like the spine absorbing the shock of walking,
and incredible shearing forces, the twisting and pulling inherent in joint movement.
This dual resistance is possible because its matrix synthesizes and contains large quantities of both type I collagen and type 2 collagen.
So type I for tensile and shear resistance.
And type 2 for compression resistance. And the ratio of these two collagens is fascinating because it adapts to mechanical forces.
For example, in the menisci of the knee, type I collagen dominates.
Right, because shear resistance is critical. But in the intervertebral discs, the ratio of type I and type 2 can be almost equal, and the overall proportion of type 2 collagen tends to increase with age.
Which reflects the continued metabolic activity of the chondrocytes trying to maintain those compressive properties.
Exactly. And a major molecular difference here is the presence of the proteoglycan versican. While fibrocartilage produces some aggrecan, it contains larger amounts of versican, which is secreted by the fibroblasts.
And versican also forms highly hydrated aggregates with hyaluronin, contributing to resilience.
Yes, this mix of fibroblast and chondrocyte products makes the tissue robust against various stresses. And as a clinical note, the degradation of the intervertebral disc is strongly linked to the proteolytic breakdown of these crucial proteoglycan aggregates,
which undermines the entire structure's shock-absorbing ability. Let's talk about how this resilient tissue actually comes into being, the process of chondrogenesis.
Most cartilage arises from embryonic tissue called mesenchyme. The structures of the head are an exception, often arising from ectomesenchyme derived from neural crest cells.
And the process starts when these chondroprogenitor mesenchymal cells aggregate together,
forming a dense knot known as a chondrogenic nodule.
The master switch for differentiation is the expression of the transcription factor SOX9.
That's the signal. The presence of SOX9 is what triggers the cells to differentiate into chondroblasts.
And once they are chondroblasts, they begin their life's work, secreting type 2 collagen and the rest of the matrix.
As they deposit material, they're pushed apart. Once they're fully enveloped by their own matrix, they are mature chondrocytes. And the surrounding mesenchymal tissue that didn't differentiate forms the protective perichondrium.
And molecular regulation is incredibly precise here. We know that the presence of the proteoglycan aggrecan itself is required for proper chondrocyte differentiation.
Which is emphasized by a serious genetic correlation. Mutations in the ACAN gene, which codes for aggrecan, cause a condition called spondyloepimetaphyseal dysplasia,
And this results in the early cessation of growth in the epiphyseal cartilages.
leading to severe short stature and, later in life, early onset osteoarthritis. It's a stark example of how a single molecular failure cascades into widespread tissue degeneration.
We should also recognize the external influence here. Biomechanical forces, the stresses and strains applied during development and throughout life, are not passive passengers.
No, they actively regulate the shape, the regenerative capacity, and the aging process of the cartilage tissue.
Now, cartilage is one of the few tissues capable of growing through two completely different mechanisms simultaneously.
At least during development.
The first is appositional growth, or growth at the surface, and this growth relies entirely on the presence of the perichondrium.
Right. Cells in the inner layer of the perichondrium, which initially look like typical fibroblasts producing type I collagen, are induced by factors like SOX9.
And these progenitor cells, they round up, increase their cytoplasm, and differentiate into chondroblasts.
And then they begin secreting type II collagen and new matrix material onto the surface of the existing cartilage mass, thus adding girth and width.
Okay, so the second mechanism is interstitial growth. This is growth from within the existing cartilage mass.
And this relies entirely on the mitotic division of the chondrocytes already residing deep within their lacunae.
This process is only possible because two things are true. First, the mature chondrocytes retain the ability to divide.
And second, the surrounding matrix is resilient and extensible. It can be temporarily stretched. The daughter cells initially occupy the same lacuna, but as they secrete new matrix material, a partition forms, pushing them further apart.
Which results in those characteristic isogenous groups we talked about earlier.
Exactly. Interstitial growth is primarily responsible for increasing the length of the long bones at the epiphyseal plates, while appositional growth adds thickness to structures like the costal cartilages.
Now, when the regulatory mechanism governing chondrogenesis goes wrong, the result can be malignancy.
Chondrosarcomas. These are malignant tumors characterized by the uncontrolled secretion of cartilage matrix.
This is the second most common matrix-producing bone tumor, typically affecting men over the age of 45.
They are slow-growing and frequently originate in the axial skeleton vertebrae, pelvic bones, ribs, or the metaphyses of proximal long bones like the femur.
And the clinical presentation is often insidious.
A deep, dull pain that may persist for many months before diagnosis. And because the tumor grows compressed within bone, it's often difficult to palpate in its initial stages, requiring advanced imaging like CT and MRI.
Prognosis is based on histological grading. Grade 1 is the least aggressive, grade 3 is the most.
And the majority, about 90%, are conventional lower-grade tumors 1 and 2 that rarely metastasize.
So if you were examining a grade 1 tumor under a microscope, what would you see?
You'd see abnormal hyaline cartilage infiltrating the bone marrow cavity. The malignant chondrocytes often appear strangely formed binucleated with pleomorphic nuclei and are frequently clustered in the lacunae. The abnormal cartilaginous matrix may also begin to mineralize.
And metastasis, usually to the lungs or lymph nodes, is primarily associated with the aggressive grade 3 lesions.
Right. And immunohistochemical markers are used to refine the prognosis. The expression of mature matrix components like type II and type X collagens and aggrecan generally indicates a better prognosis.
Conversely, the presence of type I collagen, the collagen associated with fibrous connective tissue signals, a move toward a more aggressive tumor.
Yes, it indicates dedifferentiation towards a more fibrous type, which suggests poorer prognosis.
And since these tumors are slow-growing and often resistant to chemo and radiation, treatment is primarily surgical.
Wide surgical excision. Low-grade tumors have an excellent survival rate if they're adequately resected.
Okay, so let's circle back now to the profound functional consequence of avascularity.
The striking inability of mature cartilage, especially hyaline cartilage, to heal even minor injuries.
And this lack of repair is a triple threat caused by intrinsic factors.
It is. First, the fundamental avascularity means no resident immune or healing cells arrive readily.
Second, the mature chondrocytes are immobile. They're encased in their lacunae, so they can't migrate to the injury site.
And third, Mature chondrocytes have a severely limited ability to proliferate. They just can't generate enough new cells to bridge a defect.
So repair only has a tentative chance if the injury is deep enough to involve the adjacent perichondrium.
Right. If the perichondrium is present and involved, progenitor cells might migrate and try to help.
But even then, the outcome isn't a return to native hyaline cartilage.
No, the repair effort typically results in the production of dense connective tissue, which quickly matures into a fibrocartilaginous scar.
And this fibrocartilage is mechanically inferior to the original tissue.
It lacks the complex organization of type 2 collagen required for sustained load bearing,
Furthermore, in adults, injury often triggers the ingrowth of new blood vessels.
which paradoxically makes the problem worse. The presence of new vessels stimulates the underlying bone tissue to start growing at the wound site, leading to bone formation instead of cartilage repair.
This limited repair is a massive clinical problem. It complicates common procedures like cardiothoracic surgery, where costal cartilage has to be cut.
Current regenerative medicine research focuses entirely on trying to bypass these limitations, using strategies like perichondrial grafts, cell transplantation, and delivering specific growth factors to kickstart native repair.
And that brings us to the final stage, calcification and replacement by bone.
While elastic cartilage resists the change, hyaline cartilage is highly susceptible to calcification, where the matrix is infiltrated and hardened by calcium phosphate crystals.
And this calcification is a programmed event that occurs in 3 well-defined situations throughout life.
First, in the deepest layer of articular cartilage, the calcified zone, which is in direct contact with the bone, the matrix is permanently calcified.
Second, a calcification is an essential step in normal growth, preceding the replacement of cartilage by bone during endochondral ossification.
And third, as a general part of the aging process, hyaline cartilage in adult non-articular structures, like the tracheal rings, gradually calcifies over time, making them rigid and brittle.
And the mechanism of replacement is clear.
Heavy calcification severely impedes the diffusion of nutrients and wastes. The trapped, dependent chondrocytes swell and eventually die. The calcified abandoned matrix is then systematically removed and replaced by new bone tissue.
So if you looked at a micrograph of an aged tracheal ring undergoing this replacement, you'd see the typical basophilic, healthy cartilage matrix being eroded.
And replaced by lighter eosinophilic bone tissue,
Yeah.
often with a large central marrow cavity forming where the cartilage once was.
And the removal of this calcified matrix is mediated by a specific cell type, the chondroclast.
These cells structurally and functionally resemble osteoclasts, the cells responsible for bone resorption. They're identified at sites of active cartilage resorption, like in developing cartilage, or on the deep surface of eroded articular cartilage in diseases like rheumatoid arthritis.
So the current understanding is that chondroclasts are essentially mature osteoclasts that are just capable of cartilage resorption.
You're right, they share the same lytic phenotype necessary for breaking down hard, mineralized tissue.
And that brings us through the entire life cycle, structure, and pathology of cartilage tissue.
It does.
So to quickly summarize the critical takeaways from this deep dive,
Cartilage's entire existence is defined by its avascularity and matrix dominance. Its incredible resilience stems from that dynamic tension between the stiff, tension-resisting type 2 collagen network and the expansive, highly charged, water-sucking aggrecan proteoglycans.
and remember the 3 types by their key characteristics. Hyaline cartilage is the compressive blueprint,
Elastic cartilage provides elastic recoil and notably does not calcify with age.
and fibrocartilage is the ultimate hybrid, resisting both compression and shear forces through that unique combination of type I and type 2 collagen.
And the most crucial functional lesson, I think, is the consequence of its avascularity. That striking inability of mature cartilage to undergo meaningful repair, forcing the body to use inferior fibrocartilaginous scar tissue.
Right. The sophistication we covered, from the molecular role of type X collagen organizing the lattice, to the zonal arrangement in articular cartilage, and the critical regulatory function of SOX9, it really underlines why cartilage damage remains one of the greatest challenges in modern medicine.
It absolutely does.
So we'll leave you with this final provocative thought. Since the body struggles so profoundly with repairing this specialized type 2 collagen-rich matrix, which area of research modulating those essential transcription factors like SOX9, developing gene therapies to prevent aggrecan mutations, or perhaps bioengineering entirely synthetic load-bearing matrices, Which one holds the most realistic promise for truly curing rather than just treating widespread degenerative conditions like osteoarthritis?
Something fundamental to consider as you reflect on this specialized tissue. We hope this deep dive has provided you with the clarity and confidence necessary to master this subject matter.
Thank you for joining us for this extensive discussion on cartilage histology, and a warm thank you from the dedicated team that brings you the deep dive.